Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about a rare complication of retinal detachment surgery, that is the extrusion of the scleral buccal. This is a patient suffering from high myopia who had history of retinal detachment in 2016, and she did undergo retinal detachment surgery in which encircling band was applied, pars plana lensectomy, pars plana vitrectomy, membrane peeling off, endolaser, relaxing retinectomies, heavy liquids, endodiathermies. All these things were done in the right eye where there was retinal detachment, and on the other eye, paraprophylactic laser was done. So this is the condition of the patient. In front of this photograph, you can see the retina is flat and all the surgeries have been done. Apart from this, anterior iridotomies, a large iridectomy was also done in this patient. Another fundus photograph of the patient. Here you can see all the laser burns applied and retina is flat. In this photograph, anterior segment, you can see that after 2 years the buccal moved anteriorly on the nasal side. It was 240 degrees buccal and it mobilized, but still the retina was normal, attached over there, and no problem was there, and patient was having good vision. Although the patient also had the history of glaucoma and she was on the anti-glaucoma medication with open angles on the gonioscopy. But in 2018, the buccal mobilized anteriorly nasally, which can be shown in this photograph. For 7 years, this patient also had a trauma by the hands of a child, and this is the condition now, that the conjunctiva is now getting on one side and the scleral buccal has extruded nasally, infranasally, which is shown here in this photograph. And under it, if you please concentrate, you will see some changes in the sclera also. Anterior segment photograph showing us the exposure and extrusion of the scleral buccal. The patient came to the emergency with this problem. She was having pain, irritation, redness in the eye and discomfort. Vision was not that much infected. No signs of infection was there, but definitely she was uncomfortable, and because of this irritation and this rubbing of this buccal. Another view, you can see how it is exposed infranasally, right eye. Yes, through the conjunctiva, and you can concentrate just under it. The sclera color is changing just under the extruded scleral buccal. Photograph gives us another view. The 240-degree buccal applied over there, and it extruded infranasally, but the buccal has, as a whole, has already mobilized and displaced anteriorly, and it has just come close to the limbus over there. Yes, nasal side. It has already mobilized anteriorly. Anterior segment photograph showing large iridectomy, aphakic eye, and it was myopic patient. So pars plana lensectomy was done initially, and anterior chamber is well formed, no signs of infection, mild conjunctival congestion you can see over there. Otherwise, just the extrusion. This patient presented to us with these problem. There were no signs of infection, no, if we say chemosis or congestion, no, just mild redness along that specific area over there. It was there, and IOP was controlled, not very high, as this patient is already using the combination of timolol and dorzolamide eye drops. With the history of glaucoma, pressure was controlled. As I mentioned, these scleral buccals, when extruded, they are a source of possible infection. Yes, this is a rare complication, the extrusion of scleral buccal, but it can happen. Sometimes they do intrusion, infections, exposure. These things can happen. And in these circumstances, under general anesthesia, proper subconjunctival and subtenon dissection should be done. scleral buccal should be mobilized properly, because there are strong adhesions developed over there. The conjunctiva has developed fibrosis around it, so it will not be very easy to remove the buccal. Yes, and once it has been removed over there, as I mentioned, there is some area, whatever over there is scleral melting. That area should be thoroughly irrigated and cleaned and washed with normal saline. And after that, a scleral graft 1 millimeter extra size should be placed on the scleral melting area, and it should be stitched with 80 vicryl. Yes, very important. And after that, if we have a dry AMT graft, it should be placed over the scleral patch over there, and it should also be stitched with 80 vicryl. The purpose of dry AMT and then making it wet over there is that it will help and enhance the growth of the conjunctiva and the closure of the conjunctiva. If the conjunctival defect is too much, it will help us. And after that, normal topical antibiotics can be prescribed to these patients. A regular follow-up can be done. So this was a very interesting case which I wanted to discuss with my respected audience, that sometimes these rare complications can happen. The patient presents with pain, discomfort, and irritation in the eyes. And sometimes you will see that patient has already got infection. Yes, patient has already got infection over there, and then you have to start antibiotic drops also in these patients. But main thing is the source of infection is this extruded buccal, and it has to be removed. I want to thank my respected audience for their attendance and attention. I hope this will be beneficial in their clinical practice. Thank you.